Welcome to our comprehensive review of psychiatry for the ABIM exam. This session will cover key psychiatric disorders, treatments, and considerations. Obsessive-compulsive disorder is primarily treated with serotonergic medications like fluoxetine or through cognitive behavioral therapy. First-line treatments often involve selective serotonin reuptake inhibitors due to their favorable side effect profile, with higher doses and extended trials necessary for effective response. For acute phase depression, medication should be continued for at least 6 months before considering tapering. In cases of chronic depression or severe episodes, medication should be maintained for 1 to 3 years. For those with 3 or more depressive events, lifetime medication may be necessary. Electroconvulsive therapy is indicated for treatment-resistant depression, especially when psychotic features or emergency conditions like pregnancy, refusal to eat, or imminent suicide risk are present. While there are no absolute contraindications, increased risks exist for patients with severe cardiovascular issues or recent brain injuries. Choosing the right antidepressant depends on accompanying symptoms. Duloxetine is effective for depression with pain, mirtazapine for loss of appetite, and bupropion for weight gain or sexual issues. Sexual dysfunction is a common side effect of SSRIs, and management in mild cases involves using PDE5 in males and bupropion in females in SSRI responders. In non-responders, may involve switching to non-SSRI options like mirtazapine or bupropion. In cases of no response to depression treatment, a change in medication is necessary. Partial responders may benefit from augmentation with a second medication. Abrupt cessation of SSRIs can lead to withdrawal syndrome, characterized by flu-like symptoms and electric shocks, necessitating a gradual taper over weeks. Tricyclic antidepressant toxicity involves several toxic mechanisms, including anticholinergic effects like dry mouth, dilated pupils, and ileus. Alpha-1 blockade causes hypotension. Sodium channel blockade causes cardiac toxicity, wide QRS, arrhythmia, and CNS effects including seizures and coma. Treatment can include sodium bicarbonate for urine alkalinization to counteract cardiac toxicity. Acute dystonia is sudden sustained muscle contractions. Treatment is with IM or IV benztropine or diphenhydramine. Akathisia is subjective restlessness with inability to sit still. We give beta-8 blocker, propranolol, or benzodiazepine. Drug-induced Parkinson's symptoms include tremor, rigidity, bradykinesia, masked facies. Most cases resolve after discontinuation of agent. Like if on haloperidol, patients need to be switched to low-risk agents like quetiapine or clozapine. Don't do benztropine or THP. More risk of this with first-generation antipsychotics. Tardive dyskinesia is an involuntary movements after chronic use. Lip smacking, chorioathetoid movements, stop or reduce offending drug. Right pointing arrow switch to clozapine or quetiapine. Can also add valbenazine. Clozapine requires careful monitoring of ANC levels, with discontinuation if levels fall below 500. Aripiprazole is associated with the least weight gain, while risperidone is more likely to cause extrapyramidal symptoms among second-generation antipsychotics. Neuroleptic malignant syndrome is a life-threatening reaction to dopamine antagonists, often occurring with antipsychotic initiation including typical or atypical antipsychotic agents. CUS includes antiemetics administration and withdrawal of dopamine agonist including levodopa. Neuroleptic malignant syndrome is characterized by fever, autonomic instability, rigidity, and mental status changes. These symptoms require prompt recognition and treatment to prevent severe outcomes. Treatment for neuroleptic malignant syndrome involves stopping the offending agent, providing supportive care, and using medications like dantrolene, bromocriptine, or amantadine. Benzodiazepines may be used if agitation is prominent. Serotonin syndrome treatment involves stopping the offending drug, providing supportive care, and using benzodiazepines for agitation. In severe cases, cyproheptadine, a serotonin antagonist, may be necessary. Clonus is a specific finding, with onset faster than NMS. Malignant hyperthermia is triggered by certain anesthetics, leading to severe symptoms like hypercarbia and muscle rigidity with rhabdomyolysis and metabolic acidosis. Immediate treatment with dantrolene, cooling, and hydration is crucial to manage this life-threatening condition. Lithium toxicity presents with gastrointestinal symptoms like nausea, vomit and acute diarrhea, and neurological symptoms include tremor, confusion, ataxia and seizures. It can happen due to dehydration or drug interactions. Treatment varies by severity, with mild cases with level less than 2.5, needing fluids and holding lithium. Severe cases with level more than 2.5 or neurological symptoms requiring hemodialysis. MDMA, also known as ecstasy or Molly, increases the release of serotonin, dopamine, and norepinephrine, leading to effects like euphoria and agitation. It can cause serious sympathetic effects including tachycardia, diaphoresis, tremors, dilated pupils, urinary retention, requiring careful monitoring and management. MDMA use can lead to complications like serotonin syndrome and rhabdomyolysis, which can lead to renal failure or hepatic failure. Excessive water intake during use can cause severe hyponatremia. It can also cause seizures. Treatment focuses on supportive care and managing symptoms with supportive care like benzodiazepines, cooling measures and ice bath for hyperthermia. Diphenhydramine overdose presents with anticholinergic symptoms such as flushing, dry skin, eye dilatation, fever and agitation. Unlike MDMA toxicity, which causes diaphoresis, diphenhydramine leads to dry skin and sedation. Phencyclidine, or PCP, intoxication results from its action as an NMDA receptor antagonist, leading to symptoms like hallucinations and nystagmus including horizontal or rotatory. Opioid withdrawal begins within hours of cessation and includes symptoms like nausea, vomiting, runny nose and muscle pain. Treatment involves using opioids like buprenorphine or methadone, or non-opioid medications like clonidine to manage symptoms. Herbal supplements like ginkgo and ginseng are often used for memory enhancement but come with increased bleeding risks. St. John's wort can interact with multiple drugs, including antidepressants, increasing the risk of serotonin syndrome and affecting warfarin levels. Saw palmetto is used for BPH but may cause stomach upset, while kava and black cohosh, used for anxiety and menopausal symptoms respectively, can lead to liver injury. Cognitive behavioral therapy, or CBT, is the first line of treatment for insomnia. For acute stress disorder, CBT is also the first choice, but if symptoms persist beyond a month, it may develop into PTSD, which is treated with CBT and SSRIs. Social anxiety disorder often requires SSRIs, but if it's performance-related, beta blockers or benzodiazepines may be used. Borderline personality disorder is primarily treated with psychotherapy, specifically dialectical behavioral therapy. It's important to note that loneliness and social isolation in the elderly are significant risk factors for mortality. REM sleep behavior disorder involves a loss of REM atonia, causing patients to physically act out their dreams like kicking, punching and yelling. This condition can precede neurodegenerative diseases like Parkinson's with Lewy body dementia. Narcolepsy type 1, characterized by cataplexy, which is sudden brief episode of muscle weakness or paralysis, sleepiness and awakening hallucinations, is treated with stimulants. Cognitive behavioral therapy is a cornerstone in treating all eating disorders. Anorexia nervosa may require hospitalization if severe, and olanzapine is used if CBT and nutritional rehab are insufficient. Bulimia nervosa treatment includes CBT and SSRIs, while binge eating disorder is treated with CBT, SSRIs, or lisdexamfetamine. Factitious disorder involves intentionally producing symptoms to assume a sick role, while malingering involves fabricating symptoms for external gain without any actual disease. Pharmacotherapy for smoking cessation includes varenicline as the first-line treatment, which is more effective than other options. Long-acting nicotine replacement therapy can be combined with short-acting forms to improve efficacy. Bupropion is also used, especially beneficial for patients with unipolar depression. Naltrexone is the first-line treatment for alcohol abuse, helping to reduce cravings and maintain abstinence. Thank you for watching this presentation. We hope you found the information valuable and insightful.